Sharma.
You're welcome. Yeah, there was a great discussion, and again highlights, as Dr. Doyle pointed, the complicated scenario of coal mining exposure together with smoking and the risk of cancer and then asbestos coming in between. So there's always interesting cases. We always learn every day from that. So I'm going to take you to a very different modern day lung disease called EVALI, or the electronic cigarettes and vaping associated lung injury. And going to mostly focus on our West Virginia or Appalachian experience. So for those, I know most of you are very familiar with the vaping, but for those who kind of forgotten in the last 1 year, it's a practice of inhaling inhaled vapors containing nicotine and sometimes flavoring agents via battery operated electronic device. Next slide, please. So vaping actually came to the United States somewhere around 2007. And by 2014, it had become very common, or as common as tobacco products, especially among the youth. And I didn't know that in 2014, Oxford Dictionaries declared it the word of the year. So it definitely was climbing up the popularity ladder. Next slide, please. So the question raised often to us is that if vaping has been around since 2007, then what happened in 2019 to suddenly cause the lung injury? Why didn't it happen before? And I think it's interesting, and that's why I thought that this would be insightful for the group to know. This graph on the slide is that although the vaping was going on since 2007, there was a significant uptick from 2017 and to onwards. And the main reason was that the mainstream tobacco companies started coming into the game, and there was a lot of dollars pushed into awareness and advertisement of vaping product. And there was a significant shift in the approach from nicotine replacement type of selling point in regards to vaping. It started getting sold as a cool alternative to smoking. And I think that there was a dramatic shift which happened in 2017 onward. And I think that the cases existed before that, but they were too random for anybody to put them together. If you look on the left side of the slide, in the Chest Journal, some of our colleagues as back as 2015 published a unique kind of pneumonia which was associated with vaping. Next slide, please. And since then, there's been significant evolution of the vaping devices itself. And you can see on the left side, they were cigarette-like, and they appeared almost like a cigarette in the beginning, and then they started becoming more and more technically advanced, from vaping pen to mods and pods. Now, in the last few years, they've become even more advanced, and they can be charged through an iPhone. And my personal favorite is the Stealth Puffer, which almost looks like an asthma inhaler. And this is what brought it into the mainstream, and the school vaping, which was mostly predominated into the school bathrooms, moved to classrooms because nobody could suspect it. And next slide, please. And that's kind of had been events which has escalated from 2017, 2019. So in 2019 was the first time that a cluster of young people got admitted for the Department of Public Health to take notice of it. And interestingly, they found that these young people who were being admitted for pneumonia, there was no real cause of infection, but somebody smart enough figured it out that the common thread between all of these admissions, and these happened in Wisconsin and Illinois, was mostly vaping. And that prompted CDC to start a coordinated public health investigation throughout the country. Next slide, please. And interestingly, North Carolina, around the same time in August, they published a series of 6 patients with a very similar young pneumonia admitted with no apparent reason. And what they did differently in this patients was they performed bronchoscopy on every patient. And they found out that they had symptoms, or they had findings which were suggestive of a lipoid pneumonia, which lipoid pneumonia is basically a fat pneumonia or a emulsion oil pneumonia, where some people get it when they are aspirating oil, like people use mineral oil either for constipation or sometimes as a nasal drops, and these may get aspirated, and we have known that for many years. And this pneumonia looked like that kind of a oil pneumonia. The issue is, where is the oil coming from? And the only oil they could figure it out was vitamin E, which is used as a cutting agent in vaping products, especially with THC. Next slide, please. So the question became, is EVALI really a lipoid pneumonia? Is vitamin E the real culprit? And at the same time, we started thinking, what about the Appalachian region? You know, is this the same true for us? Are we seeing cases? Are we missing those? Are there any regional variations that we should be aware of? We couldn't find any local data, so we started our own investigation here in West Virginia. Next slide, please. So at the same time, University of Utah had performed the same kind of series in their set of patients, and they also found lipid-laden macrophages in the bronchoscopy. But they came up with a very interesting finding that this fat macrophages or fat-induced macrophages didn't look like the usual oil aspiration pneumonia. And yes, there was fat in the macrophages, but it seemed more endogenous than exogenous. So it means that it wasn't coming from external sources. This was a fat which is kind of produced as a part of an inflammation of the lung. And I think even a medical student can recognize the differences in the 2 slides as to how big vacuolated, biopsy results are seen on the left side, which is what you see in typical lipoid, while there are macrophages laden with oil on the other end, but those are more endogenous. Next slide, please. So the question is, vitamin E, is this really the culprit? Is this the silver bullet? And this big study was conducted in which over 50 patients underwent a bronchoscopy. And then there was a control of 99 patients who did not vape, and they had a bronchoscopy. And what they found was that 49 out of 51 patients who were vaping had vitamin E on lavage. And at that point, it was, very clear, and everybody settled on this belief that this is truly a lipoid pneumonia, and that truly the silver bullet of this injury is vitamin E, which is an oil or cotton or agent. Next slide, please. Except when this large report was published in New England Journal, which was a conglomeration of many hospitals reporting their cases. So we had over 2,500 hospitalized patients with EVALI. 60 of them died, and their mean age was 24. So again, it's a young people's disease. What interesting finding in this was that 1/3 of the fatal cases reported only nicotine use. So where that kind of put the theory of vitamin E into suspect, because vitamin E is a cutting agent used for THC-based vaping and is not necessarily used in nicotine-based vaping. Nicotine uses a different type of a solvent called the PGVG. So if vitamin E was not involved in 1/3, then there must be something else causing the damage or the EVALI. Next slide, please. Here's a very interesting case coming from Mayo, who collected lung pathology. So instead of lavage, they actually had biopsy samples of the lung of subjects who had undergone damage to the lung because of EVALI. And surprisingly, they did not find any vaping or oil type of injury macrophages. Instead, they found acute lung injury, they found organizing pneumonia, and they found diffuse alveolar damage, which suggests intense inflammation in the lung and very akin to what's called as the chemical injury to the lung. On the right side, similar findings were published by a separate group in Cleveland Clinic, suggesting that this was suggesting more of a chemical injury than a lipoid pneumonia. Next slide, please. So CDC then came in that, vast majority still looks like it's vitamin E kind of a damage, but don't rule out other chemical implicating damage to the lungs from vaping. So vitamin E was still a suspect, but people started realizing that there's more to the story than just vitamin E. Next slide, please. So why has it been so difficult, despite such an intense national search, to identify the offending agent in EVALI? Next slide, please. Well, here's the big reason. As opposed to cigarette smoking, which is very contained, the contents of the smoking, the tobacco, where it's coming from, the composition of vaping products has, by and large, remained very secretive. There are many, many products and many chemicals involved, from nicotine to THC, cannabinoid oils, solvents used in these products are like vegetable glycerin and propylene glycol, along with vitamin E acetate, as I alluded. There are flavoring agents which are now being used in vaping devices like diacetyl. And then on top of that, there are contaminants and adulterants, example like polycyclic aromatic hydrocarbons. Toxic metals have been found in vaping products. So there's a whole array of chemicals out there which are unaccounted, which we don't know about. Next slide, please. So if this wasn't enough, then it's not as simple as taking a puff from smoking. There are different techniques and devices which can play a role in lung injury. For example, vaping can have variations in how you inhale these vapors. For example, a process called dabbing. In dabbing, they actually use a blowtorch to heat up a wax type oil and inhale that. In dripping, these oils are actually dripped into a burning coil and inhaled directly. Not to mention, some patients do Valsalva maneuver, which means they're trying to pour and get a bigger hit out of each of these vaping devices. On top of that, there are different inhalation devices which are out there in the market. One of them is called the mouth to lung, which looks like much like cigarettes, where you inhale, keep it in your mouth, and then slowly get into the lungs. But now there are bigger and more powerful versions of these, which are called direct to lung, in which you can breathe directly from the device into the lung, and they are much more capable of causing damage to the lung. So these kind of introduce an element of significant variability in terms of dose, products, ability to get lung damage can vary quite a bit. Next slide, please. So CDC and FDA came with these recommendations somewhere late 2019 that we don't know really what the culprit is, but of what we can say, do not use THC containing e-cigarettes, not use any informal sources like getting from friends, families, or online dealers, because they have higher contents of contaminants, flavoring agents, so on and so forth. Vitamin E was still a suspect, so they told all the manufacturers not to use or add them in e-cigarettes as a cutting agent. And of course, people should not add any other substance on their own to these products. Next slide, please. So these recommendations did help, and by January of 2020, we had seen reduction in EVALI patients and reduction in use of THC-containing products, which we thought was the main culprit. Next slide. So what about here? So we were as concerned listening to the initial outburst of this epidemic in Wisconsin and Illinois. In August of 2019, our section formed a vaping injury task force. And the idea behind this task force was to very carefully monitor all cases admitted with suspected EVALI and do a thorough workup, documentation, and then appropriate treatment and then document that. We also got IRB approval to be able to review these cases for research purposes. Next slide, please. So our method was all patients admitted to West Virginia University Hospital with any respiratory symptoms screened for vaping. And the total number of patients between August 2019 and March was 17. As I alluded, IRB approval was taken to further analyze these patients. Next slide, please. So we stuck to the CDC definition of EVALI, which I'll reiterate again, is basically use of e-cigarettes or dabbing in the 90 days before the symptom onset. You have to have a chest X-ray or a CT scan showing either infiltrate or classical ground glass appearance on CAT scan. And then there has to be absence of any known infection on initial workups. The minimum criteria included getting a respiratory viral panel for influenza and other viruses. And there should be no other medical alternative plausible diagnosis, for example, cardiac, neoplastic, or rheumatological. So this was what was defined as CD as a confirmed case of EVALI. Next slide, please. And there was a second category called probable EVALI, in which everything was the same, except that there was an infection found in the lungs. However, the clinician felt that the severity of the disease which the patient is having currently does not match to the number of the infection in the lung. So a mild rhino or adeno virus in the lung with minimal infiltrate shouldn't put you in an ICU, intubated, or an ECMO. And at that time, we felt that this patient injury cannot be explained purely by the infection. Next slide, please. All patients were seen by pulmonary consultants. All had a CT scan of the chest. Majority underwent fiber optic bronchoscopy, total of 15. Most reason for that was they were extremely sick. We wanted to rule out infection. One of the big reasons to rule out infection also was the fact that at that time, the best treatment for EVALI was high-dose steroids, almost to the range of 1 milligram per kg per body weight. So we did not want to induce a high-dose steroid treatment without ruling out infection. And again, because there was this growing suspicion of a lipid-laden macrophages causing lipoid pneumonia, we wanted to evaluate for that. And we were also interested in iron stains, and we sent them out for Prussian blue testing. We also did something which other series has not done, is that we approached the patients and asked them to voluntarily share with us the products that they were vaping. And you can imagine most people were very hesitant on doing that, but 6 patients came forward and brought their vaping paraphernalia for us to further evaluate. Next slide, please. So these are some of the results. If I may bring your attention, first is that there were 14 confirmed EVALI cases based on the CDC definition, and 3 patients were probable. As you can see, we had very sick people 59 or 10 patients were in ICU with either ventilation, non-invasive or invasive. 2 additional patients were sick enough to be placed on ECMO. So very sick population from EVALI. On the top, if you look at it, few patients did have pneumonia, and I wanted to bring out what kind of infections. So one patient had a viral rhinoenterovirus. The other one had a combination of a rhino plus strep pneumonia. Another one had strep pneumonia and Klebsiella pneumonia. 9 of them, which is around 53%, stained positive for oil redo stain, which is suggestive of oil-based or lipoid pneumonia. Considering that how sick these patients were, almost all of them were discharged alive, and only 1 died post-discharge. And I'll talk about that later. Next slide, please. So this is a fairly typical finding on a CAT scan of a patient who vapes. You can see this ground glass appearance with some sparing of the subpleural areas. The reason I put this image also is not only one of our patients who represented, but to see the flip side of it is that 20% of the patients will not present with this typical GGL appearance. In fact, 20% of them would have crazy paving pattern, consolidation, just like you see in pneumonia, or nodules, which may even raise suspicion for malignancies and other things. So don't be swayed by the appearance of GGL while present in majority of the cases. It certainly is not a sine qua non for vaping disease. Next slide, please. And you can see another red herring in this whole situation is leukocytosis. 82% of these patients had high white count. So imagine a chest X-ray showing an infiltrate and white count showing elevated. It's very easy to miss this diagnosis if you don't grill the patient and take a very comprehensive history about vaping. Vaping also comes with other bad players. We found that 53% of the patients tested positive for urine drug screen. Most of it was accounted by THC or marijuana. Next slide, please. Vaping behavior, just I alluded before, these don't come in one nice, neat packages, but you can see that 53% reported just using nicotine. However, substantial number of patients reported both nicotine and THC. Vaping, substantial number of patients used flavored compounds. Many were sharing their devices. As I mentioned, they were using techniques like dabbing, Valsalva, which can cause significant lung damage and are very different than the traditional vaping. Next slide, please. These are some baseline characteristics, and there's a lot of information. Now let me walk you down through some of the main components of that. So as I alluded in my previous slide, several of the studies I alluded to you, it's a young people's disease, mean age group from studies to studies ranged from 21 to 24. But look at us in West Virginia. The mean age group was around 37 years. This has not been reported anywhere in the country that much older folks are getting involved with vaping and getting much severe lung disease. Coming down from respiratory was very similar to the national data, which we had already knew that dyspnea or shortness of breath on exertion was present in 100% of these patients. Cough was a predominant symptom of this disease. And in some cases, pleuritic chest pain was also accompanied. Another thing I wanted to point out is that many of these patients have significant GI symptoms. So don't let the absence of respiratory symptoms make you believe that this is not a vaping injury. A lot of these patients present with GI symptom, nausea, vomiting, abdominal pain. And then you can see that is true not only nationally, but even in our series, 53% of the patient had either GI symptoms concomitant to respiratory or predominantly GI symptoms. Next slide, please. So what were the results of the lavage? So the lavage was targeted for 3 reasons I alluded: rule out infection and evaluate for foamy macrophages, which is a type of a marker or biomarker for what is called as the Laporte pneumonia, and then look at the iron stains through Prussian blue to see what kind of damage is happening in the lungs. And we found 9 patients had evidence of foamy macrophages. So remember that not all of them had foamy macrophages in there. And all of these foamy macrophages, according to our pathologist, did not suggest exogenous oil infiltrate, but was more aligned to what we had seen from University of Utah and Mayo Clinic, that it was a more endogenous production of lipoid. 4 patients had high level of hemosiderin-laden macrophages, which is a lot of tremendous amount of iron in the lung. And just to give a little background of that, iron is essential for all living beings, and DNA synthesis and repair requires iron. In essence, all bacteria need iron to reproduce. In fact, if you wanted to kill and destroy every bacteria, just take away iron from them. So that's how important iron is. And that's one of the reasons, as humans, we have much lower iron levels in the lungs, because as part of the evolution, we knew we need to protect the lungs. And if you had very high quantities of iron in the lungs, then that lung would become predisposed to bacterial infection as being the only organ exposed to the environment. But the bacteria are smart, because the environment has a lot of iron. So if you are working in a coal miner area, if you are exposed to substantial air pollution, cigarette smoking, all of that can increase the amount of environmental iron exposure in your airways. And the bacteria, even if there is not much iron, comes ready with this packaging of iron from the environment. So the story of iron, it becomes a little bit more complicated, is because when a lung is injured and there's significant inflammation in the lung, and part of the healing brings iron into the lung, which in regard then further predisposes the lung to infection. So in our opinion or mind, iron in the lungs, especially in the lavage, was a marker of a significant lung damage, not necessarily because of vaping. So if you look at the data from our West Virginia EVALI patients, 4 patients who had the hemosiderin or iron were the sickest of them, either on ECMO or on a ventilator. Next slide, please. So these were some of the paraphernalia our patients brought in voluntarily. And this is a picture I took of them in my office. I believe at one time I had more paraphernalia in my office than a vaping dealer. All of this then eventually was went through the proton transfer reaction mass spectrometry for chemical analysis. Is one of the most sensitive ways of figuring out what kind of chemicals are we dealing with. So next slide, please, Mitchell. So look at the amount of chemicals. These are the chemicals we found through mass spectrometry in this vaping compound: formaldehyde, acetaldehyde, acetone, propylene glycol, cyclohexane, nicotine, monoterpenes. Monoterpenes are, by the way, plant derivatives mostly found in patients who are vaping THC or marijuana. And an anti-inflammatory compound which has never been isolated in the past called linalool. So we were surprised by the amount of chemical diversity that our patients were smoking and inhaling in their lungs. Next slide, please. What was very surprising and very unique in our patient in West Virginia as compared to other case series that have come across the country was the high level of TVOCs, or what we call as volatile organic compounds. And the sicker the patient, the higher the levels of the volatile organic compounds we found in the vaping products. Next slide, please. And I'll come back to that VOCs in a minute, but I wanted to dwell a few minutes on the follow-up of these cases. Next slide, please. So what happened when these majority of, as I said, actually, despite, believe it or not, being that sick on an ECMO and ventilators, 100% of them were discharged to home alive. But believe it or not, 25% of those patients, despite being sick as a dog, resumed vaping. And one of them actually died within 3 weeks of that. So, if somebody is got this notion that this is not addictive, look at these numbers. And the other thing which we were surprising was that even when this agent or this insult has ceased, as you can see that 75% of the patient did stop vaping, 33% continue to have symptoms even 2 to 3 months post-discharge. In fact, one patient remained on oxygen for several months despite discharge. So there's a lingering residual damage with the vaping, which may exist for many, many months, and it doesn't go away. Next slide, please. So, when we analyzed our samples and our patient care, we realized that there were some factors which were coming into play again and again, and it was that the sickest patient had marijuana or THC vaping as part of their MODS. We found that many of them were also addicted to opioids, which was very surprising because this wasn't seen in significant other series. And then, as I alluded, that volatile organic compounds were found in patients who were the sickest. And let me take a minute on volatile organic compounds. These are like formaldehyde, acetaldehyde. You can find them in very common house, environmental things. Like, for example, they are found in shampoos, they are found in kerosene, cosmetics sometimes utilize them. If you are inhaling and tobacco, you can get significant amount of formaldehyde. Kerosene burning can cause that. So these are some local products, but they can cause significant chemical injuries to the lung. And this brings us back to the original article where it was whether this is a Lippard pneumonia versus a chemical injury. At least in West Virginia, what we are showing is that the predominant injury in the lungs seems to be a chemical injury, and the agent which is causing the most devastating lung injury seems to be the volatile organic compounds. Next slide, please. And this is a comparison to just kind of give us a little context. There's 2 studies. On the left side is a study done down the street from Pittsburgh, Pennsylvania, on vaping injury, and this on the right side is our West Virginia. Look at that, just 70-mile difference. There's a significant change in the mean age. Their study again shows, consistent with the national data, that's a young people's disease. Not so much in West Virginia. Much older crowd is involved with vaping. We have much more women, having EVALI as compared to the Pittsburgh or Pennsylvania study. Our population had the most devastating vaping injury, with 47% intubated and on mechanical ventilation compared to only 19% in Pennsylvania. We had much higher percentage of drugs in the system. So to think of multiple ways of damaging the lung, including THC, opioids, cocaine, and meth, as compared to the other series. We had more bronchoscopy samples than the Pittsburgh series. And we did chemical analysis on 35% or 1/3 of the population, and there was no chemical analysis done in the Pittsburgh series. Next slide. So in conclusion, I think what we learned from West Virginia, and we are glad that we did our own, was that we can't depend on data from outside West Virginia, that our patient population seems to be much more critically ill from EVALI as compared to other national series. Our mean age of patients getting EVALI is much higher than nationally reported. And we are finding chemical injuries secondary to volatile organic compounds or total volatile organic compounds, which is in alignment with the pathology findings from Mayo and Cleveland Clinic showing chemical burns, and not in alignment with the oil-based pneumonias, which the rest of the country has reported. And we find significant higher impurities in the vaping products in West Virginia, most likely the reason being that there are much more garage labs here in West Virginia producing vaping than legitimate companies. Again, dabbing, dripping, Valsalva, all these techniques which they are inhaling these products in can cause even more damage to the lung. So with this, I hope I gave you a little insight, well, not only of nationally, but also honing it down on our own state. I think this issue is not going to go away as we see the pandemic receding away. These will come back into the forefront, and these were just temporarily either butted or not being paid attention and faded in the background. But I think that vaping is not going anywhere. We're going to see a lot more of it as we go forward. So I wanted to make sure that all physicians in West Virginia are aware of our data and can easily pick up on vaping injuries of the lung. So with that, I'll open to any questions, comments.
Thank you so much, Dr. Sharma. That was really excellent. And I did want to direct everyone's attention to the chat for this last minute here. Dr. Doyle had mentioned that many patients continue smoking after cabbage, and it's just a reminder of the grip of nicotine addiction. Dr. Sela also mentioned that she sees patients all the time using vaping as a way to quit smoking. And Aaron Erb had asked a question a little earlier on asking, is there any risk of secondhand smoke in person and or in apartment buildings?
Yeah, so secondhand smoking, we know for a long period of time can be as harmful, if not more, than people who are firsthand smoking. And that's one of the reasons you see smoking being barred in bars and other common areas. So yes, it's implicated. Whether secondhand vaping is as lethal as that is yet to be determined as we gather more and more data. This is a very young disease. Remember that the first cluster just came in 2019, and all research on vaping abruptly stopped last year, March. So a lot is still to be learned about this disease and how it impacts not only the lungs, but other organs. We are continuing our research with our partners in physiology and biochemistry over here at WVU. And hopefully in a year's time, I can update the group on other things we have learned about.
We would certainly love that, Dr. Sharma. It's always wonderful having you on here. I don't want to hold you all longer than we have to, so I will just jump into announcements, but big shout out to Dr. Doyle for presenting the case at 5 a.m. over there. We truly appreciate it, and daylight savings, if I can say that too. And Dr. Sharma, thank you as always for the wonderful presentation. Always love having you here. So our next session will be on April 5th, and Dr. Panagakos from the dental school will actually be guest speaking for us on oral and respiratory health. So keep an eye out for that reminder, and we look forward to seeing you all next time. Thank you so much, everyone.
Thank you.